First of all, thank you very much, Dr. Zira, Dr. Hanna, for the invitation to this conference here in the Kingdom of Bahrain. It's a great pleasure and a great honor for me to be here and to speak about an orthopedic subject, the arthroscopic procedure in patients with rheumatic diseases. So, first I want to show you where do we see an indication for such a treatment. Then I want to show you which joints can we scope. Is it possible in all joints of the body or not? Do we need a special technique if you try to treat a patient with a rheumatic disease? And what can we expect? Which are the results? We could hear in the morning session that there's a big improvement in the diagnostic tools of joint assessment by ultrasound and MRI, but the arthroscopy plays still a very important role in the management of inflammatory arthritis. This is the only possibility, the only way now to have a direct and precise inspection of the joint. And we have the possibility to collect synovial membrane samples as biopsies of an excellent quality. And this I will show later in some studies, we can also reduce the pain. But what's very important to have the right indication? It's very important to distinguish between soft tissue problems, the extra-articular problems, from the joint problems. That means from problems which are caused by an intra-articular damage or structure. And we have to distinguish between an inflammatory syndrome from a non-inflammatory syndrome. As you can see here on an MRI of the knee joint, you see this is the patella, this is femur, and you can see here thickening of the synovial tissue. When do we have an indication for an arthroscopic treatment? First, it's an intra-articular problem, and if we want to have a biopsy of the synovial membrane. If we have an inflamed synovia with symptoms fail to conservative treatment, that means if you saw in the morning all the drugs that we can give the patients, but if you have permanent pain, permanent problem in the joint, maybe we should do an operative solution. But when should we do it? You see here 6 months. Is this the right moment, the right date? I don't know exactly, but I will show you later some data. What can we do? We can do a partial synovectomy. We can do a total synovectomy. We can remove the loose bodies. This is very easy. And maybe we can also repair some cartilage defects. If we see the literature and the numbers of patients, we see that 65% of all studies, of all patients, are studies where a knee problem is treated. And all the other joints that you can see here are very rare. There are some new joints for the arthroscopic approach, maybe the hip joint. Is it possible to look inside the hip joint and to remove the synovia of the hip joint? I will show you later. What can we see? What can we do? First of all, the knee. We have, in the normal arthroscopic field, some standard portals. The standard portals you can see here. Here's the patellar tendon, an anteromedial, anterolateral approach to the knee. With these two approaches, you can treat 95% of all patients with meniscal problems, cartilage problems, ligament problems. But if you want to do a synovectomy, a total synovectomy of a knee joint, you need additional approaches. And you see here in the front, these are the additional anterior approaches, but you have also to look to the posterior part of the knee joint. And then we need a posterolateral approach or a posteromedial approach, because we want to see 100% of the synovia of the knee joint. Then we have to distinguish between a localized problem and a diffuse type of synovitis. On the left MRI, you see the knee, lateral view. This is femur, this is tibia, this is the posterior cruciate ligament, this is anterior. And here you see some synovial problem. You see there's a thickening of the synovia, you see the effusion of the knee joint. And if you have such a patient with a localized type of synovitis, you can treat it by an arthroscopic procedure very easily. But if you have such a situation as you can see here, the same look, lateral view, this is femur, this is tibia, you see here the patella, the quadriceps tendon, patella tendon, and you see everywhere synovial tissue. And even here, you see a very thick formation. So is it possible to do by an arthroscopy? Here, the arthroscopic procedures are very limited. And these kind of patients you have to treat by an open approach. What can we do? We can do a synovectomy. You see here a shaver. We can remove the synovial tissue. As you see here, this is the anterior cruciate ligament. You see here some synovial tissue. This is not very difficult to reduce the synovia. We can remove the loose bodies, and we can do an arthrolysis. That means we can improve the range of motion of the joint. And in some cases, we also can do a cartilage repair. What can we do with the cartilage? If we have a loose part of the cartilage, we can do a refixation, if it's possible, only in the first days, if the cartilage has a good quality. We can remove the loose bodies. We can do a debridement. That means just shaving the cartilage surface of the bones. And then we can try to do a resurfacing. If we have deep defects of the cartilage, maybe one of the different options can be used. What's very easy is to do a shaving of the synovia. You see here. This is a patella, this is a femur. You see here the shaver, here's some soft tissue, and just we can shave it. This is very easy. It's much more complicated if we have a very deep defect. You see here. This is a normal cartilage. You see here a deep, localized defect. This is bone here. And then we have 3 different options. It depends on the size and on the localization of the defect. Very easy is to do a microfracturing, you see here, just to put some holes into the bone by a so-called chondropic to activate the bone to cover the defect again. We have these possibilities here. It's called the osteochondral transplantation if you have a bigger defect, or here also the chondrocyte transplantation. But I can tell you, in patients with a rheumatic disease, this is very, very, very rare. So maybe in some cases we use this here, microfracturing, just to recover the surface. I want to show you some case reports. This is a 30-year-old female patient with a pigmented villonodular synovitis. She had a former ACL reconstruction that you can see here, and the pain started 2 years ago. This is the X-ray, and you see that it has the signs of osteoarthritis. There's no more, there's very narrow joint space. You see the osteophytes here. This is the interferential screw from the ACL reconstruction. And you can see even here, the bone is not normal. If we see the MRI here, you see it's completely not normal. You see here the kind of soft tissue, the synovitis in the anterior parts of the joint, the posterior parts of the joint, and you see also here not only erosion, you see a bony defect, a big bony defect. So even if we plan to give to this patient, this age from 38 years, to plan to do a knee replacement, we need good bone for a good knee replacement. So what can we do in this case? In this case, we did an open anterior and posterior approach to remove the synovia, and then we filled the bone with bone to prepare the implantation of a knee prosthesis, maybe in a few years. Now, patient feels very much better, but we cannot say what will come in the future. This is another example. A case report, 62-year-old female patient with a RR. Pain started 10 years ago. And you see here, this is not possible by an arthroscopic procedure. You see we have synovitis in the anterior parts. You see it here. This is in the proximal part of the tibia. You see in the posterior parts of the joint. This is not possible to treat by an arthroscopic operation. I want to show you some studies around the knee first. So this group here from Netherlands, they compared the simple needle aspiration with an arthroscopic lavage of the knee. They could find that the group of the needle aspirations had a 3 times greater risk of recurrence of arthritis in needle aspiration within the first 12 months. And they had a lower risk of recurrence of arthritis in patients with a longer disease duration and if they had more drugs before. So I think we can use a needle aspiration if they have much pressure in the joint, but it's not a very good solution for the future. If we have these kind of localized types of synovitis, as you see here with the pigmented villonodular synovitis, you remember this picture before, we have a study here from Italy. They examined 19 patients with a follow-up of 5 years, and they could find that if we have a localized form of this kind of synovitis, we have a complete and persistent regression, but if we have a diffuse form, it's much more difficult. Then we have a better clinical result with an extended synovectomy compared with a partial synovectomy. Then it's always a question, can we do the synovectomy open or can we do it arthroscopically? There was a big discussion in the last years whether we should combine such a synovectomy with radiation. Here you see a study from the Journal of Arthroscopy in 2011 from Germany. And they combined it and they did a 14 years follow-up. 38 patients with a follow-up for 14 years. And they could show that we have a stability or an improvement of the function of a knee in the first 5 years. But after 14 years, 50% of the patients needed a total knee arthroplasty. And always a question, open or arthroscopic? What's the difference? Here another group from Germany, they compared arthroscopic procedure with an open procedure, and they could see, after 6 months, that all patients with an arthroscopic procedure had a significant decrease of blood loss and a shorter duration of hospitalization, and had a greater mean flexion and range. But they had no difference in postoperative analgetic use or the extension range. Another study, they treated 42 patients with a follow-up of 16 to 20 months. They used the visual analog scale for the pain and then function score, the Ogilvy score. And they did an arthroscopic procedure with what I showed you, 2 to 5 approaches, or an open procedure with 2 approaches, one anterior with more than 10 centimeters length, and one in the posterior part of the knee, also with more than 10 centimeters of length. They could show that they had the same scores after treatment, but the patients with an arthroscopic procedure had a fast recovery and less pain. What can we see? What can we do in the other joints? So the ankle joint. Even here we have some standard approaches, but if we treat a patient with a synovitis, we need additional approaches. Usually, it's enough to see here, this is the ankle joint, in a normal arthroscopy to do an anteromedial and anterolateral approach. This is enough to reduce some loose bodies, to resect some osteophytes or so, it's enough. But if we want to do a total synovectomy, we have also to reach the posterior parts of the joint. So we have to go in this direction. So we always use a different technique in these patients with synovitis. What can we do? Here you see a look, an arthroscopic look in the ankle joint. This is the anterior distal part of the tibia. This is the talus, and you here see the soft tissue. And now you can imagine if this patient would do a dorsal extension of the ankle joint, you have a kind of impingement in this area. So what can we do? We can resect this synovia, and we also can resect some osteophytes. You can see here. This also is the same situation, the tibia, talus, synovia here. You see here these osteophytes, and then we can remove it by different techniques. Here you see with a burr, and then we have a situation, as you can see here in the X-ray, the lateral view. Here's the osteophyte, and here we could remove the osteophyte, and then patients should have a better range of motion. And most patients, as you can see here, before had synovitis, a reduction of the mobility, had pain, and had to reduce the sporting activities. And even in the joint, in the ankle joint, we can do the same procedures with the cartilage problem, as we did it in the knee joint. We can do a microfracturing, synovectomy. You see here the kind of microfracturing to treat this cartilage defect here. And then in the control, we can see what happens with the defect. And after sometimes 1 to 2 years, we can reach a resurfacing of the cartilage surface. Do we have some studies? We only have one study concerning the ankle joint in patients with rheumatoid arthritis. You see here only 18 patients, follow up 12 months, and they could show us that 15 patients had clinical success after 1 year treated by an arthroscopic synovectomy of the ankle. Now to the hip. Is it possible to see inside the hip, to do something in the hip? It's possible. As you can see here, we need special instruments. This is a hip joint. You see here, this is a femoral head. This is a neck region. We have a central compartment here, and you see this is very narrow. We cannot look inside. It's very difficult also to do an injection in the hip joint, though this is not easy, and this is a peripheral compartment. So we need different scopes, different objectives, and then we have to release the capsula, and we need an extension table, as you can see here, that we have enough place to look inside the joint, in the central part of the joint. You can see here in extension, we need 10 to 15 millimeters of relaxation, of traction of the joints that we can go inside with a scope. So we can look in the central compartment, and if we bend the hip, we can go in the peripheral compartment. And if we can treat both compartments, we also can treat a synovitis of such a joint. Which kind of options do we have for the therapy? We have the same as in the other joints. We can do a biopsy, we can do a partial and total synovectomy and arthrolysis. We can treat cartilage defects, lavage, debridement, chondroplasty. We can remove loose bodies. It's the same. But we have another problem with the hip joint. We can see all areas of the joint, but we cannot reach them by the instruments, because we have a problem that we don't have flexible instruments to reach the posteromedial part of the joint. With a scope of 70 degrees of angle, we can look to this area, but we cannot reach it. This is a problem in the hip joint in every kind of disease. It's not only in the rheumatic diseases. I want to show you one special case report. It's a very young man, 24 years old. He had an RR. The pain started just 3 months ago, and he went to his doctor, and he did an X-ray, and what could you see here? The right hip, nearly normal, and the left hip, osteoarthritis. And that's a problem. 24 years old, pain just started 3 months ago. He had a crepitation, he had to use the crutches, he couldn't move the left hip. What should we do in this case? If this patient would be older, 50, 60 years old, there wouldn't be a big discussion. We would recommend to do a hip replacement. But 24 years old, just 3 months, maybe you have a situation to do an arthroscopy. So we did, in this case, we did an arthroscopy, even if you see here the MR, the right hip is normal, and you see here, it was a very big problem. You see the edema in the bone, this is the head, you see there's no more cartilage here in between, you see there's a big defect, a big erosion in the femoral neck region. So it seems to be a very aggressive type of a synovitis. What we did, we looked inside, we removed the inflamed synovia that you see here with the shaver, and you see this is the head of the femur, and here you see the fovea centralis, it's the central part of the acetabulum, and so we tried to remove the synovia as much as we could, but I can tell you we couldn't reach all regions of the joint. But we will see what happens with this patient. I think in this special situation, we can try to improve to reduce the pain and to improve the range of motion. And maybe we hope that this patient will have good result in the next month and maybe over the next years. What have we to consider in the postoperative management? It's very important to perform good compression after such an operation. Because if we remove the synovia, and we remove it from the capsula, we always have a risk of bleeding, because this synovia, the inflamed synovia, is very well perfused. So that's why we always need a very good compression in all joints that we treat by an arthroscopy or even with an open approach. Usually, we give the patient some crutches that they should use the crutches for 2 or 4 weeks. It depends on the joint that we treat. We recommend to do some physiotherapy and lymph drainage to reduce swelling. We remove the stitches after 2 weeks, and we recommend to do an MR control after 6 months. What can we say to the other joints? What are the results? You see here a study about the effectiveness of arthroscopic synovectomy in rheumatoid arthritis. And we always have the aim to reduce the pain, to improve the joint mobility, and we could see that we have better results if you see several studies together in an early synovectomy, especially in shoulder, elbow, wrist, and knee. And it seems to be better, an open procedure, if we have a late stage arthritis in elbow and also in the small joints. But, as you can see here, the real joint preserving effect has not been demonstrated. So it's the same with the same situation as we had with the drugs. We cannot cure the disease. Here you see a meta-analysis, 58 studies, 36 with an open approach, 22 by arthroscopy, more than 2,500 patients, follow-up, mean follow-up, 6 years. And they could show that in the arthroscopy, we had nearly the similar pain reduction compared with the open procedure. We had more frequent recurrences, but a decreased risk for a total knee arthroplasty. What's about the elbow? We just have 2-3 studies that I want to show you. Here a study from Japan. They could show us that we have one very important prognostic factor in the treatment of the synovitis of the elbow. If we have a preoperative arc of flexion of more than 90 degrees of flexion, then we have better results. But if we they did a literature research about elbow arthroscopy in patients with RR. We have not good evidence for arthroscopy of the elbow. The only evidence that we have is for the treatment of problems around the knee with these patients. One study with wrist and elbow arthroscopy, you see they could improve pain, the joint motion, they can reduce the inflammatory markers, and had also better disability score treated by arthroscopy. But in all these studies, you see they only treated just 15, 20 patients and not more. This is a problem in the scientific world with these patients. I want to summarize. An arthroscopic procedure is indicated if we have to do a partial or total synovectomy, if we want to improve the range of motion by an arthrolysis, if we want to remove loose bodies, and if we have a localized cartilage defect. We have best experience in the treatment of the knee joint, but sometimes we also can treat patients with other joint problems, hip joint, ankle joint, shoulder or elbow joint, but we need a special technique. We have best results in knee arthroscopy, we have a localized form of the synovitis, and in all other problems, in all other patients, if we have a diffuse form of a synovitis, and especially in the small joints, we should treat them by an open procedure. But at the end, I want to tell you it's very important to treat every patient individually. Every patient is different. Thank you very much.